internal medicine specialties. And then we have the Limi Children Hospital, which is located in Wuse 2. And we deal with all sorts of pediatric conditions with specialty in pediatric cardiology, pediatric neurology, and neonatology up to adolescent pediatrics, pediatric medicine. So, who are we? The Limi Children's Hospital is a designated specialty hospital for pediatrics, neonatology, and adolescent medicine. And what drives us? We as a hospital, we are driven by our vision to become and remain the leading regional world-class patient-centered children's hospital, working with appropriate innovative technology based on godly principles. And we have a saying, a healthy child is a happy child, and a happy child makes a happy home. So this is what drives us. So now to get into the main topic for today, we will be talking all about the child with abnormal heart sounds. And your presenters are, I am Dr. Emmanuel Ugwo, and with me I have...
Okay, I am Dr. Igoche Peter. Happy to have this joint presentation today.
Welcome.
Yeah. So we would like to talk about everything about the child whose heart sounds are abnormal. Yeah, so our objectives. By the end of this presentation, we want to be sure that we've highlighted the appropriate use of the stethoscope. So it's interesting that every doctor hangs a stethoscope on the neck, every nurse, every CHU, every veterinary doctor, every medical student, hung on the car or kept on the dashboard. But how do we use it? When we talk about frequencies of heart sounds and then when to use the bell, when to use the diaphragm. We also want to relate the heart sounds we hear with the phases of respiration and the cardiac cycle. So some heart sounds are physiologic, others are pathologic. Yeah, so those ones that are pathologic and are murmurs, we want to appreciate the timing. So if it's the first heart sound and there's a murmur that starts with it, what kind of murmur is that? And then at the end, we want to be able to identify murmurs that are innocent. So some murmurs are guilty, some are innocent. All right.
Okay, so this is just going to be our brief outline. We're going to talk about the heart sounds, cardiac murmurs, and how to evaluate children that we see with cardiac murmurs.
Yeah.
So for the heart sounds, generally the heart sounds, they are audible sounds that are heard following the vibration set up by the turbulence of blood flow across the heart valves during the cardiac cycle. So a cardiac cycle has a systolic, a diastolic. So as the blood is flowing through each phase, we hear some sounds, and that's what we call the heart sounds. And most times,
so this heart sound generally, we are hearing it because the blood flow has a velocity and something is happening to the flow velocity. The valves are closing. And you know, we have the inlet valves, the mitral, the tricuspid, we have the outlet valves, the aortic, the pulmonary. One thing about heart sounds in general is that the valves, as they are passing through the valves, either the valves are closing for the normal heart sounds or something is wrong with the valves. So there's a vibration that is set up and the sound waves are picked using the stethoscope. Now, what are the parts of stethoscope, if I may ask?
So the stethoscope has two parts, majorly. Well, except we want to talk about the entire stethoscope, both the earpiece, but majorly the two parts that we're concerned about.
Yeah, of course. Yeah.
We have the diaphragm and the bell. So
yes.
Okay,
so if we look at the bell, if you look at it, the spelling bell has a shorter spelling than diaphragm, which is longer. So the shorter one, bell, is for lower frequency sounds, and the longer spelling, diaphragm, is for higher frequency sounds. So what are these low frequency sounds?
So low frequency sounds, we have some like some mid-diastolic rumbles. A pulmonary regurgitation murmur is also a low frequency sound that can be heard, and some innocent murmurs like a Stills murmur. It's part of the a
Yeah,
low frequency murmur that can be heard. But
yeah.
interesting to note that the bell can actually also be used to hear high frequency murmurs. It's not just low frequency murmurs, but for that, you need to press the bell firmly on the chest and you'll be able to pick up a high frequency sound.
Yeah, so if I may ask, we see some doctors with their diaphragm damaged, the diaphragm of their stethoscope damaged.
Mm.
And most times, once the diaphragm is damaged, it's assumed that the stethoscope is useless. Okay, so if we know that, then we'll know that placing the bell lightly will pick low frequency sounds, and placing the bell firmly will give us the same cardiac or auscultatory sounds like the diaphragm. But however, we know that the stethoscope is not used only for cardiac auscultation. So you need it for the respiratory sounds, you need it for bowel sounds. So the bell and the diaphragm, they're important. Now, the question is, if we have doctors who have never used the bell for auscultation of cardiac sounds, then I put it to you that we have missed all low frequency sounds, right? So if the idea is always to use the diaphragm, then the point is that all low frequency sounds have been missed because the diaphragm will not pick a low frequency sound. All right.
Unfortunately, that's it. So, but then, at least for people that still have their diaphragms working, it's used to pick only a high frequency sound, unfortunately. So sounds like the second heart sounds can be picked with the aid of the diaphragm.
Yeah.
Okay. So for the heart sounds, generally we have the heart sounds we have four major heart sounds. We have the first heart sound, the second heart sound, third, and the fourth heart sound. So for the first heart sound is associated as a result of the closure of the mitral valve and the tricuspid valves, which are also called the inlet valves because blood flows through them into the ventricles. And most times the closure of the mitral valve is most audible at the apex, while that of the tricuspid valve is most audible at the lower left sternal border.
Yeah, so at this point, as though I should ask our audience, what is the definition of apex? Because
What's the
if
definition of what?
you cardiac apex, not you, our audience, because if you don't know the apex, you see, if you say it's just fifth left intercostal space, what of a child that has a dilated cardiomyopathy? You will not get it at the fifth left intercostal space, right? So the apex is the lowermost, outermost point of maximal cardiac impulse. So if you want to auscultate for the mitral valve closure, it is not always fixed at the fifth. Of course, for infants, you are getting it at the fourth left intercostal space anyway. So the ability to palpate the lowermost, outermost, maximal point of cardiac impulse tells us the apex for where we'll pick the mitral valve activity, closing as S1.
Exactly. Then for the second heart sounds is associated with the closure of the aortic valve and the pulmonary valve. And usually it has two components, which is the aortic component and the pulmonary component, designated as A2 and P2, and is best audible at the upper left sternal border of the chest during auscultation. Okay. So when it comes to the splitting of heart sounds, we're still talking about the first and second heart sound. So for the first heart sound, it splits and the mitral valve closes before the tricuspid valve. That's what brings about the splitting. It closes because there's more pressure that occurs in the left side of the heart. So naturally, the mitral valve will close before the tricuspid valve. But this is not something that is meant to be normally heard. In fact, it is an infrequent finding in normal children. But In cases where it's found, abnormally wide splitting can be found in cases of right bundle branch block or in Epstein's anomaly. So,
Okay.
but when we're talking about a splitting of the...
Okay, so let's talk a little about this splitting of S1. So S1 has a mitral valve component and a tricuspid valve component. They should close at about the same time, although mitral valve closes before tricuspid valve, but they're so synchronized that we hear it as one sound. Now, if for any reason the lob, we hear lobbed up, if the lob is splitting, it can occur in right bundle branch block. So what happens? In right bundle branch block, the impulse transmission from the synovial node to the AV node and even to the Purkinje fibers and all that. So there is a bundle branch block of electrical activities to the right side. So what happens is that the contraction before it closes on the right side delays. So you clearly hear the mitral valve component first, and then the tricuspid valve component will lag behind. Therefore, the S1 is splitted. So if S1 is ever splitted, it's not normal, right? So
Okay. So, but for the second heart sound, it is a natural occurrence for it to be split. It is usually heard at the pulmonary area, and it has two components, the aortic component and the pulmonary component. So the aortic component is the first one that is heard in the split, while the pulmonary component is the second one. And this you hear it very well on inspiration, because when there's inspiration, more blood is being taken into the heart and there's more blood entering into the right ventricle. And because there's more blood in the right ventricle, to pump it out through the pulmonary valve, to delay it, so the aortic component would naturally close before the pulmonary component. So when we're auscultating, especially during deep inspiration, we hear the split actively.
okay, so let's do some practical explanations on the splitting of the S2. So if we hear lob, dop, lob, dop, lob, dop, so lob is occurring at as the S1, dop is as the S2. Now, the problem many younger doctors have is you are hearing two heart sounds. Which of them, therefore, is a lob? Which of them is the dop? The explanation is just like the way we count heart rates using our stethoscope and then count pulse rates by palpation. So if we place our hands for an older child on the carotid pulse, and then simultaneously we are auscultating the heart sound, you are hearing one, two, whatever, you are hearing two sounds. Whichever sound corresponds with the pulsation of the carotid artery is the S1. The other sound that sounds almost similar is the S2. Now, the second heart sound will be single during expiration, but like my co-presenter has said, during inspiration, because of the larger diastolic filling of the right ventricle, it will take a longer time before it empties in the ejection phase before the pulmonary valve closes. So it accounts for the splitting. So if we hear lob, dop, so it sounds like this: lob, dop, lob, drop, lob, dop, lob, drop. Because lob, dop for expiration and a drop for inspiration. So the inspiratory phase, you hear two similar sounds very close to each other. Now, when this is heard, it's not a murmur. Our common observation is, oh, please do echo for this child. I heard an abnormal sound. And one of the reasons for this presentation is so we can comfortably say, this sound we are hearing is a split of S2, and how the split is, it's a murmur, so that we are making requests with confidence. Yeah.
Okay. So for abnormal second heart sound, so we have different types of abnormalities that can be heard with the second heart sound. It could either be widely split or a fixed split, that's a fixed split second heart sound. It could also be narrowly split. It could be paradoxically split. So for a widely split and fixed second heart sound, it can be occasionally normal in children. But when we see it, pathological conditions that we can see it in when there are cases of volume overload. So in cases like ASDs, um, partial anomalous pulmonary venous return, can also be as a result of pressure overload, like in pulmonary stenosis.
Let's take it this way.
Okay.
Why are we likely to hear a fixed defect? The point is S1 during expiration, they are together. That's the pulmonary and the aortic component, while the S2 in inspiration, they are separated by gap, which is split. Now, for any reason that increases the volume of the right chambers of the heart, the pulmonary component will close later than normal. So in atrial septal defect, the pulmonary veins empty blood into the left atrium, and the left atrium normally should empty through the mitral valve to the left ventricle, but some blood will seep via left to right shunt into the right chambers, increasing the volume of blood in the right chamber. So in addition to the blood that came from the inferior superior vena cava, so volume overload will occur in atrial septal defect, in partial anomalous pulmonary venous return, and making the blood, increasing the ejection phase before the closure of the pulmonary component of S2. So in atrial septal defect, there is a fixed splitting. Normally, in inspiration, it's there. In expiration, it will be found. So also in partial anomalous. Now, in pressure overload, what happens is that there's pulmonary stenosis. So even though it's a normal volume of blood, the outflow tract is narrower than usual. So it will take a longer time before the right ventricle empties itself, and until the right ventricle empties itself, before the pulmonary valve will close. So it takes a longer time to close. So the S2 will be widely split. It will take a longer time. The same explanation for right bundle branch block. The time for ventricular depolarization before it contracts takes a longer time from the Purkinje fibers before it will contract. So volume overload, pressure overload, electrical delay. Interestingly, if there is something that makes the aortic component close earlier than normal, so S2 is widely split. If P2 closes too late, or A2 closes too early. So if there's aortic, if there's mitral regurgitation, when the blood is being contracted, the ventricle contracts to eject blood. Some goes backwards through the incompetent mitral valve. So not everything is going out. So the little that goes out, the aortic component closes faster. And even though the pulmonary component will close when it should close, it seemingly will have a wide splitting of the second heart sound. Yeah.
Yeah. Okay. And then an abnormal sound with the second heart sound, it can also be narrowly split, and can also be occasionally normal in children, like in cases of pulmonary hypertension, aortic stenosis too. You might hear a narrowly split S2.
Yeah.
We can also have cases of single S2 where only one second heart sound is found, even during inspiration, deep inspiration. We can hear it in cases of severe pulmonary hypertension, severe aortic stenosis, or when there is presence of only one semilunar valve, that is either the aortic valve or the pulmonary valve. And in cases where the P2 component of the second heart sound is not audible, like in cases of transposition of the great arteries and tetralogy of Fallot, So these are conditions where you hear only one part of the second heart sound. Then in a paradoxical split, in this case, instead of the A2 coming before the P2 here now comes before the aortic component. So this can be seen in severe aortic stenosis where enough blood is not going to be pumped out, and in left bundle branch block where there's interference with the electrical conductivity in the left aspect of the heart. So it will make the pulmonary component of the second heart sound to occur before the aortic component. And we can also have an abnormal intensity of the P2. So it can be increased in cases of pulmonary hypertension and decreased in cases of severe pulmonary stenosis, tetralogy of Fallot, or ovarian trifid stenosis.
All right, fine. So let's just give a practical explanation of these splits. We explained the wide splitting. So we are hearing lop, dop, lop, drop. So in inspiration is lop, dop. In expiration is lop, drop, right? So if it is widely split, you hear the clear lop, dop in expiration. And then in inspiration, when it should split, it becomes lop, drop. So the splitting is longer, that's wide. For single S2, regardless of the phase of respiration, you just keep hearing lop, dop all through. So if a doctor says he was auscultated and you heard lop, dop all through, then you are sentencing that patient to severe pulmonary hypertension or severe aortic stenosis, right? So it's important we know that. Now, when we say the intensity of P2 is louder, so we are hearing it at the pulmonary area, and it's really louder than what is usual. So it's just to practically, so when we have the stethoscope on our ears, auscultating the precordium, we can actually explain what we are auscultating. Yeah. All right, so let's see. There may have been some confusion so far in our minds. What causes S1? What causes S2? What accounts for S3? What accounts for S4? The beauty of cardiology is that it's not far from cardiovascular physiology. So that's it. Now, if we look at the cardiac cycle, which is a series of electrical activities, cardiac cycle defined as a series of electrical activity that occur in the heart from the beginning of one heart sound to the beginning of the next heart sound. That definition should be clear in our head. Now, it has the phase of the diastolic phase, and it has the systolic phase. Again, this should be very clear in our minds. Now, the diastolic phase has two phases, and the systolic component has two phases, right? Sorry, I don't mean two-phase Idibia, the musician, anyway. Okay, fine. So what happens is we have four phases here: isovolemic relaxation phase, the filling phase, the isovolemic contraction phase, and then the ejection phase. Let me start from the end, which is the terminal part of the ejection phase. Let's assume the left ventricle has pumped out blood. So when the blood has been ejected from the left ventricle, the aortic valve closes because that phase has closed. That phase has closed. So closure of that aortic valve when the ventricle has emptied itself, that closure, imagine blood was flowing and the volume that should go out is completely out. Regardless of the little volume there, the valve snaps closed. So once it closes, there's a vibration set up, turbulence set up, the vibration, we hear it, that is S2. Now, if that is understood, start from the point where you know that the outlet valves are closed. When it's closed, you see the ventricle has emptied itself. The next thing you want it to feel. So in isovolemic relaxation, the aortic valve is still closed from after the ejection of blood. And then the mitral valve is also yet to open. So there's a low left ventricular pressure, which creates a gradient because, I mean, a balloon has emptied itself, is flat, seemingly flat. So there is a negative pressure created, and that forces a suction of the mitral valve to snap open. When the mitral valve is opened, in this phase, remember the aortic valve is still closed. Mitral valve opens, so blood flows from the atria, from the atrium, passively across down the pressure gradient from the atrium, which has more blood, to the ventricle at that point that has very low pressure. So it fills up the left ventricle. The rush of blood, that rapid filling of the ventricle in the filling phase of the diastole of the cardiac cycle creates some turbulence leading to S3. So S3 is the sound we hear from the turbulence set up when the left ventricle is rapidly filling up. Now, we know that more than 70% of the left ventricular filling is a passive process. Now, but for the atria to completely empty itself into the left ventricle, that's the left atrium, there's a slight contraction, which is about 30% of it, to complete the filling phase of the cardiac cycle. That slight contraction is S4. We will see subsequently that it's actually a soft, it's a low frequency sound. So back to our the parts of the stethoscope, you will not be able to hear it with the diaphragm, right? Even the S3 is a low frequency sound because it's from passive filling. So if we have always only used the diaphragm, then granted you've never heard an S3. Good. So the left ventricle is now full. So the filling phase of the cardiac cycle gives us two heart sounds, right? So when it is full, we now get into the isovolumic contraction. The expanded left ventricle now forces backwards the mitral valve to snap close. So the mitral valve now closes up because the pressure down has built up enough to close up the mitral valve. So it closes. That closure of the
So the closure of the mitral valve is what causes the first heart sound to occur. And after that, the aortic valves now begin to start opening because of the pressure that is building up in the left ventricle. So the aortic valve is opening, but it's not yet fully open. So, but because of the pressure, the blood is, as the pressure is building up, subsequently it leads ejection phase, which where in that phase the aortic valve now opens up and blood is allowed to flow through it. Please, can you hear me? Am I audible? Can someone put it in? Let me know if I'm audible. Okay. So for the we have some extra heart sounds. That's the third heart sound and then the fourth heart sound. So for the third heart sound, which has been explained, it is a low frequency sound, but this occurs early in the diastolic phase, and it's as a result of the rapid filling. And it's very physiological. Hearing it does not indicate a pathology. So it happens because there is sudden feeling. Hello, can you hear me? Okay, so there is sudden filling of the left ventricle as a result of opening of the valves, and it is usually, but it becomes abnormal when there is an excessive dilation. So because the chamber in which the blood is meant to enter is now bigger, the sound it's going to make is going to be louder than it would have been in a normal situation. And this can occur in cases of a decompensated large shunts like a ventricular septal defect, and also in clear-cut cases of dilated cardiomyopathy. because there is a failure of the systolic function. So if there is tachycardia present, you would usually hear a Kentucky gallop.
Yeah, so let's say this. So if we say the first heart sound is Ken and the second heart sound is talk, the third heart sound, because it's a low frequency sound, it goes with the yi. So two consonants and one vowel. So you see that the first heart sound is loud, Kentucky, Kentucky. So however you want to call it, the first is clear, the second is clear, the third heart sound is soft. So the gallop rhythm is created, the Kentucky gallop is created if we have those situations where there is systolic heart failure. Yes. So what of the S4?
Okay. So for the S4, this, the S3 was an early diastolic low frequency sound. This now is a late diastolic frequency sound. It occurs in the later part of diastole where there is atrial contraction. So the difference between this and the S3s are in S4, the left ventricle is not compliant. So it is stiff, is refusing to bend, is refusing to allow the blood to just freely enter. So that when the atrium contracts, the force of the contraction and the entry into a very uncompliant left ventricle creates that low frequency sound. So it's usually heard
Okay.
as.
Okay, exactly. So, but then the thing is,
Hello, Dr. Peter.
yeah.
Thank you. So if the tachycardia is present, it's usually heard as a Tennessee gallop. So, but to practically explain it, the most times the S4 starts before the first and the second heart sound. So what we'll be hearing, the S1 and S2, they are already lub dub. So what we'll be hearing is talab dub. So that is a practical way to pinpoint when there is an extra heart sound, a fourth heart sound. So moving on to murmurs. Murmurs generally, they are abnormal heart sounds that are caused by the turbulence of blood flow as a result of an imbalance between the velocity of the blood flow and the size of the orifice in which it is passing through. So most times these are the abnormality in the orifice that occurs as a result of maybe narrowing. That's when it's tenuous, so the hole reduces, the outlet of the hole reduces, or there's an incompetent valve. In an incompetent valve, blood flows through the valve, but instead of it to completely close, it's still open, allowing blood to flow back. So you hear that murmur, or in cases of a shunt, like in a ventricular septal defect, in an atrial septal defect. And to analyze these murmurs, we'll be analyzing it based on the location, that's where it is heard loudest when you're auscultating, the intensity, that's the grade 1 to grade 6, the pitch, if it's a crescendo or a decrescendo, the profile, and then the timing. So this is just a brief pictorial representation of the location of murmurs where we can hear murmurs when we are auscultating. So in the aortic area, we hear a systolic murmur, which can be seen in aortic stenosis, in normal physiologic murmurs, in aortic valve sclerosis. Then we have the pulmonary area. So in the pulmonary area, we can hear systolic ejection murmurs. We have the pulmonic stenosis, the atrial septal defect, flow murmurs. Then we have the tricuspid area, where we hear holosystolic murmurs like tricuspid regurgitation, ventricular septal defect. And we also hear diastolic murmurs like tricuspid stenosis. Then we have the mitral area. Holosystolic murmurs can be heard like mitral regurgitation, systolic murmurs like mitral valve prolapse. Then we have an extra area known as the Erb's point, where we hear diastolic murmurs like atrial regurgitation, pulmonic regurgitation, and we also hear some systolic murmurs like hypertrophic cardiomyopathy. Usually a trick that was used in school to remember all these areas, we have all police take money. I am not the one that said it. It's just something that was used to remember. So all police take money for the point that we can hear different murmurs. So when grading, when we're grading a murmurs, we're grading it based on the intensity of this. Now we're talking about systolic murmurs. So for systolic murmurs can be graded from grade 1 to grade 6. And in grade 1, it is faint, it is barely audible. Most times, it needs a quiet room, a cooperative child, and the heart rate needs to be relatively slow. And naturally, I mean, we're in pediatrics, so this is a bit difficult to get all these three in a pediatric child because, I mean, children are already uncooperative, especially the younger ones. And the more they cry, the more catecholamines are released, the more their heart rate is elevated. So most times, we just try to make sure, give them a little things that can distract them to be able to get this grade 1. But most times it is picked up by a specialist, by a cardiologist. But for a grade 2 murmur, it is a soft murmur, but it is also readily audible. So from this grading, it can easily be heard by a layperson, not a specialist. Then we have a grade 3 murmur, which is easily audible, but without a palpable thrill. So, but by the time we can now start feeling the murmur, we are palpating what we are hearing on auscultation. It now becomes a grade 4 murmur because now at that point, there is now a palpable thrill. So our hands will be placed on the chest at the precordium, and then we'll be able to feel this thrill, and then it becomes a grade 4 murmur. But by the time the stethoscope is not fully placed on the chest, instead it's tilted maybe to like a 45-degree angle, and you can still hear the murmur, the grading increases now to a grade 5 systolic murmur. And in grade 6 murmur, you don't even need your stethoscope to be on the murmur, to be on the chest. The murmur is easily heard. Okay. So for diastolic murmurs, the grading of diastolic murmurs, we have a grade 1 murmur, which is barely audible. Grade 2 is audible, but it is soft. Grade 3 is an easily audible murmur. Grade 4, we have a loud murmur. So this is the grading of a diastolic murmur. So now when we're grading murmurs based on the pitch, it either is a crescendo murmur, meaning that it is gradually increasing to a peak intensity. It starts off small and gradually peaks and continues to peak. So that is what we call a crescendo murmur. But a decrescendo murmur, it starts loud and then it starts tapering down from the initial peak that it was at. And then we have what we call a crescendo decrescendo murmur because it will start small, builds up, it reaches a peak, and then it starts reducing, it tapers off and reduces in sound to continue again. And then a plateau, where the intensity from the beginning to the end is the same. There's no increase, there's no reduction. Everything is just the same. So the image is shown beside it can help us picture it in our minds to be able to identify it. Okay. So when it comes to the timing of a murmur, the timing of murmurs, it can either, depending on at what phase of the cardiac cycle that these murmurs are heard. And we've already established that we have two broad phases of the cardiac cycle, the systolic phase and the diastolic phase. So for a systolic murmur, the murmur will be heard at the beginning or after the first heart sound. And then, but the murmur finishes before the second heart sound or at the point you are hearing the second heart sound, at the beginning of the second heart sound, which is different from a diastolic murmur, which usually will occur after the second heart sound or at the beginning of the second heart sound and end just before or at the beginning of the first heart sound. So these are pictorial representations of the timing in which the murmurs can occur. And despite it occurring either in the systolic phase or diastolic phase, it can either be an early, mid, or a late murmur. So That's for the timing. Is either a systolic murmur or a diastolic murmur. So, so in the organic
Okay,
pathology,
so if we
Dr. Peter, sorry, you were saying something.
so if we look at structural, if we look at structural pathologies that can cause murmurs, we've already established in the previous slides that murmurs are either systolic or diastolic, broadly speaking, although we also know that if it goes both ways, then it's continuous murmurs. Now, if you want to look at the structural pathologies, let's make it very easy. The ventricles have an inflow tract, which is the mitral valve, the tricuspid valve. And it has the outflow valves, which are the aortic and the pulmonary valves. Now, if the inflow valves, inlet valves are too loose, the abnormal sound we will hear will be a systolic murmur. If the outflow valves are too tight, which is stenosis, it will create a systolic murmur. Inversely, if the inlet valves are too tight, that's inlet valve stenosis, it will give a diastolic murmur. If the outlet valves are too loose, that's outlet valve incompetence, it will give a diastolic murmur. Let's go through it like that and see. For example, if we have mitral valve incompetence, right? We know that at the isovolemic contraction phase of the cardiac cycle, which we discussed, the mitral valve should, just before the mitral valve should snap close for blood to go. That's S1. The mitral valve, once it closes, the mitral valve closes, creates a first heart sound. But in this case, it is incompetent. It's closing and not closing completely. So with the ventricle contracting, blood is going backwards. So it gives a regurgitation. So blood is regurgitating. So it's giving us a regurgitant murmur, right? Now, if the outlet valves are too tight, at the ejection phase, when blood is supposed to be ejected from the left ventricle, the outlet of the left ventricle is too tight. So high velocity of blood flow across an orifice that is narrower than normal sets up greater turbulence. So there's an ejection systolic murmur in that regard. But subsequent slides will explain it better. But for systolic murmurs, inlet valves incompetence, outlet valves stenosis, diastolic murmur. So for the diastolic murmur, if the inlet valves are stenosed, for example, mitral valve stenosis, in the filling phase, blood should enter passive, but there is an obstruction because it's not filling phase, which is a diastolic, which occurs in the diastolic aspect of the cardiac cycle. It's not filling as it should because there's an obstruction to the inflow. It creates a diastolic murmur. For the outlet valve incompetence, similarly, it causes diastolic murmur. But subsequent slides will explain this better as we progress.
Okay. So we had explained previously. Okay.
So looking at cardiac cycle again, this is cardiac cycle phase 2. The initial description of cardiac cycle was for us to identify where S1 occurs, where S2 occurs, where S3 occurs, where S4 occurs. We established that S3 and S4 occur in the filling phase of the cardiac cycle. We established that S1 occurs in the isovolemic contraction phase, and we established that S2 occurs at the ejection phase. Now, so let's just come down to regurgitant murmurs and ejection systolic murmurs. So for regurgitant murmurs, if the inlet valves are incompetent, then when the ventricle is contracting in the isovolemic contraction phase, blood will be regurgitating through the valves, just like I said on the previous slide. So we get a regurgitant murmur. That murmur that is regurgitant is also called a holosystolic murmur or a pansystolic murmur. In the ejection phase, if the outlet valves are stenosed, it means there's obstruction to the ejection of blood at the ejection phase of the cardiac cycle. So it's trying to eject, but there's an obstruction to it. So it sets up that turbulence and we get an ejection systolic murmur. Yeah.
So this is just more details about this the systolic types of systolic murmur, for example. So regurgitant murmurs, they are always organic. So we can see it in a left-sided regurgitation. That's in cases of rheumatic mitral valve incompetence or mitral valve prolapse. You can see it in tricuspid regurgitation, which is involving the right side of the heart, or as a result of the presence of a shunt in a ventricular septal defect in between the right and the left chambers of the heart. But we also have ejection systolic murmurs. So now these ejection systolic murmurs, we have to take note that they can either be functional or organic. Functional meaning that there is no particular specific structural defect or issue that has to do with the heart, but is associated with a high cardiac output. So, but in organic ejection murmurs, there is a heart defect. So it can either be as a result of a left ventricular outlet tract obstruction, like in aortic stenosis, aortic valve stenosis, or hypertrophic cardiomyopathy. It can also be in a right ventricular outlet tract obstruction, like in pulmonary valve stenosis or pulmonary infundibular stenosis, where the outlet valves are restricted. Okay. So in systolic murmurs, more explanation about the ejection. Now we're talking about the ejection systolic murmur.
Yeah.
So, okay. It occurs between.
So the important thing here is that
Dr. Peter?
So the important thing here is that we can clearly identify, granted, so far in the presentation, it's taken for granted that we can identify S1 and we can identify S2. Now, to identify S1, we said your stethoscope in your ears on the precordium and one of your fingers on the carotid pulse, and the first heart sound is simply the sound that corresponds with the pulsation you are feeling. That is the first heart sound. Now, for an ejection systolic murmur, you distinctly hear the first heart sound. You distinctly hear the second heart sound. But then there is an abnormal sound in between, which takes a crescendo, decrescendo pitch. So, for example, you hear lob, dop, lob, dop, lob, dop. That's normal. But now you are hearing lob, vroom, dop, lob, vroom, dop. So you are hearing lob clearly, you are hearing dop clearly, and there's one sound in between, which is not of the pitch of the first or the second heart sound. So you're hearing lob, vroom, dop, lob, vroom, dop. It's an ejection systolic murmur. But the holosystolic murmur, we had earlier said that it starts with or after the first heart sound, and it runs the entire systole with a plateau kind of pitch. So it's the same kind of pitch till just before or with the second heart sound. So if you are hearing lob, you should hear lob, dop, dop. But in this case, you're hearing lob, dop, lob. So the lob is not ending distinctly, and it just occurs also. So lob, dop, like that. So you hear the ejection systolic murmur, two distinct heart sounds with a muffled, unusual sound in between. For pansystolic, well, there is one sound that corresponds with your position, which you don't hear to the end, and then there is murmur attached to it. Yes.
So in diastolic murmurs, like in cases of aortic regurgitation, it has a decrescendo pitch and usually begins early in the second heart sound, starting with the aortic component. and it sounds like it has a blowing sound. While that of pulmonary regurgitation, it also begins early, but begins with the pulmonary components, and it's also decrescendo in pitch,
Yeah, so we had earlier said that some sounds, the frequencies of some sounds are high, frequencies of some of the sounds are low. It just calls to reason that the frequencies of sound in diastole will be low frequency sound. So if you are hearing an early diastolic murmur, either because of aortic regurgitation or pulmonary regurgitation, you're hearing lop, dop normally, lop, dop, lop, dop. They are loud, they're high frequency, and lop, dop, lop, dop, lop, dop. So there's an component that starts with the second heart sound. So granted you've auscultated, you are sure that there is one sound that you are hearing that is corresponding with the peripheral pulse. You hear that sound distinctly. Then there is the second sound, you hear it, but just after that sound, there is a lower pitched sound in a decrescendo pattern. So that's early diastolic murmur. Now, there is also the mid to late diastolic, which could occur in which is a mitral valve rumble. Yeah. So in that case, the late diastolic sound is actually a pre-systolic sound. So it will be difficult to say lop dop, then before the murmur, then the first heart sound. So again, it's like lop dop, lop dop, because it's pre-systolic, and the first heart sound is systolic. So lop dop, but this is lop dop, lop dop. So if as physicians we do not use the bell of the stethoscope, I put it to us that we will almost always miss diastolic sounds. And if because of this presentation, we start using the bell of the stethoscope, but we press it with so much energy, we will still miss the diastolic. So the bell of the diaphragm placed on the auscultatory areas lightly will pick up low frequency diastolic.
Now, for a continuous murmur sounds like a machine. It's a machine-like murmur. So this they usually say it will sound like a washing machine, and you hear it at the left infraclavicular area, just under the clavicle. So it usually starts with the first heart sound. It peaks at or just at the start of the second heart sound, or it can go beyond that, and then it reduces in the pitch during the diastole, and it's usually a high pitch sound. So for this one, we can hear it freely with our diaphragm, but we prefer the bell because it can help us in case there's another one. So it can be heard in conditions like PDA, that's patent ductus arteriosus, or aortopulmonary windows. So these are examples of continuous murmurs.
Yeah. Okay, so still on the continuous murmur. So if you put on a washing machine, you hear when the sound starts. So it's like there's a sound there. So that's how the continuous murmur of a PDA or a large aortopulmonary window goes. It's almost like there is so that sound you're hearing is the first heart sound, then you will not hear the second heart sound. So it's just that sound you are hearing is corresponding with the peripheral pulse. You will not hear another heart sound. You will just hear that muffling crescendo pitch of a murmur. Then you still hear that sound that corresponds with the peripheral pulse. So if we do not auscultate the precordium simultaneously by palpating a pulse, then we will not be able to say, oh, see, this is this type of murmur. That is it. Okay.
So after hearing all the different types of murmurs, now to evaluate a child with a murmur, we've already known that it has to do majorly with auscultation. So it follows a stepwise approach. So we're going to time the heart sound to know which is the first heart sound by palpating the carotid or the brachial artery. And then once we hear the first heart sound, we have to identify the intensity, the variability, and localize it. Then we'll also listen for the second heart sound to hear if we're hearing a split, if it's associated with any respiratory changes, like during inspiration, expiration, or it's constant throughout. If the pulmonary component is loud. So one of the most important things to characterize is actually the second heart sound when we're listening for the heart sounds. Then we would like to listen for the third and the fourth heart sound, which if there's a fourth heart sound, is always pathologic. And then we would also listen for a systolic murmur, then listen for a diastolic murmur. So to listen to when evaluating a child, we place the children in different positions. We listen while the child is lying in supine position, and then also while the child is sitting, and then also during expiration and inspiration to know the different variabilities that can happen.
Yeah. So this tells us that a junior doctor telling a senior doctor, oh, it's like I heard a murmur. And then the senior doctor comes, places stethoscope with one hand in the pocket, places stethoscope on the chest, and say, this is a pansystolic murmur. Now there's going to be a problem. Or this is an ejection murmur. There's a problem. I may accept if you say a continuous murmur because you just hear one sound and hear the womb sound across. Evaluating a murmur, it takes a stepwise approach. It's stepwise. So the sound you will be able to hear, you should be able to tell what the first is, what the second is, what are the variabilities in the first, the second, the timing, and then this last, listen to the heart in different positions. The subsequent slides will tell us what is the difference if it's in supine position and what is the difference in sitting position. So it's saying murmur is not just like spot diagnosis, just like that. Because the purpose of the presentation is that by the time you are sending a child to me for echo, you are auscultated and you are almost sure of what I'm going to give as the conclusion. So if there's a discrepancy, you can laugh and say, no, it doesn't tie up, because clinical skill must not be lost. That is one reason of this echo. Anyway, send the patient, you will not be disappointed. You only realize that your clinical skills tied up with the echo diagnosis. Yeah, so let's look at positional changes. Yeah.
So positional changes that occur with murmurs. In the supine position, with supine position, there's an increase in the end diastolic volume because there's going to be an increased filling of the ventricles. And as a result of the increased filling of the ventricles, there will obviously be more blood pumped out of the heart, which will increase the stroke volume, which is different from sitting or in standing position. So as a result, any outflow tract murmur will be increased when in supine position, and then the murmurs will obviously be louder, with the exception of hypertrophic cardiomyopathy, where the small intracardiac volume in sitting and standing position increases the left ventricular outlet obstruction, and as a result, in those cases, the intensity of the murmur will be increased. But every other outflow tract murmur, it increases.
Yeah, so it's important. If you think there is a murmur, the child should sit on the examination couch, and after you finish your auscultation, just cram or imagine the intensity of that murmur and let the child go supine. When the child goes supine, the murmur should ordinarily be louder, with the exception of the hypertrophic cardiomyopathy that was stated, because in supine position, more blood is flowing passively as the venous return. Venous return is increasing passively, so more volume of blood. And then when there is the site of turbulence, more turbulence occurs, and we pick it as louder than when the person is either standing or sitting up.
Okay. So these are the other maneuvers and what we expect to see as a result. In inspiration, there's increase in the venous return in the right atrium. As a result, there will be increase in right-sided murmurs and a decrease in left-sided murmurs. Expiration increases the left atrium venous return, and the left-sided murmurs will be louder, while the right-sided murmurs will be reduced. But if you lean forward, you're bringing the the aortic valve closer to the wall, so the aortic murmurs will be increased. But in a left lateral decurvatus position, the mitral valve will be closer to the chest wall, so the mitral murmurs will be heard louder. Then anything that increases the venous return, squatting, raising the leg, or also lying in supine position, it increases all the murmurs except a mitral valve prolapse and the hypertrophic cardiomyopathy, where it decreases them. And anything that decreases venous return, standing, Valsalva maneuver, it decreases all the murmurs except for the mitral valve prolapse and hypertrophic cardiomyopathy. And anything that increases the afterload, because you're already blocking an already stenosed area. So you, like in cases of hand grips, you should be increasing the aortic regurgitant and mitral regurgitant murmurs, but it reduces the intensity of aortic stenosis and mitral valve prolapse and a hypertrophic cardiomyopathy murmur. So this is just a slide for us to read through.
Yeah, so just to ask, how can we, maybe the audience will look into the type into the Q&A. How may you do Valsalva maneuver when you're, because if we just say this and you don't know what to tell the patient to do, how will you check? So a patient that has a hypertrophic cardiomyopathy, if the patient stands up, the hypertrophic cardiomyopathy will be louder. If the patient does Valsalva maneuver, it will be louder. So what is Valsalva maneuver?
So
Expect
the Q&A box to be full.
Okay, so because we won't keep people waiting for so long, first expiration against a closed glottis is Valsalva maneuver. The person is trying to bear down, that will cause that. It's okay, thank you.
Okay. So this is just a brief algorithm for investigating a heart murmur. So when we hear a heart murmur, we need to evaluate if it is a diastolic murmur or a systolic murmur. So if it begins, okay.
So this algorithm, actually, if we can follow it, we assume that listening to this webinar was a big success, right? Because if we say continuous murmur, we have explained continuous murmur. Remember the sound that the washing machine makes. So if we hear that, our mind goes to a patent ductus arteriosus. Next thing, send for echo, right? We also know that a large aortopulmonary window will also cause that sound. And that sound you're hearing at the left infraclavicular area, it goes for a PDA, a patent ductus arteriosus. Now, what if it is a diastolic murmur? What is a diastolic murmur? How, at what phase of the cardiac cycle do we hear diastolic murmur? It is in diastolic. How do we know we are in diastolic? It is that I said, stethoscope on the chest, your hand on the peripheral pulse, the sound that corresponds with that palpation is the first. The second, the other sound that sounds like it is the second heart sound. Now, if you hear the murmur that comes just after that second one, is an early diastolic murmur, right? So now, for diastolic murmurs, it begins loud with the second heart sound and then decrescendos, right? That's a diastolic murmur. Fine. The aortic regurgitation, again, we said that diastolic murmurs are heard with outlet valve incompetence outlet valve incompetence. So aortic regurgitation from aortic incompetence will cause an early diastolic murmur. Good. If the murmur begins in the middle or later part of the diastole, in that case, it is a pre-systolic sound. So stethoscope on the chest, with your, of course, earpiece on your ear, and then your hand palpating the peripheral pulse. The other kind of diastolic murmur is that there is a heart sound you are hearing very close to that, the first sound that corresponds with the palpation of the peripheral pulse. Then an unusual muffled sound comes just before that heart sound. Then the heart sound you hear, then the second heart sound. So we say, lobbed up, lobbed up, lobbed up. So it's like a pre-systolic diastolic murmur, which is a mid to late diastolic murmur. You are thinking of a mitral valve stenosis. So inlet valve stenosis for a mid to late diastolic murmur, and then outlet valve incompetence for a late diastolic murmur. The concern here now is if we are dealing with a systolic murmur. How do you know it's a systolic murmur? In this case, you are able to identify that this sound is the first heart sound because what you are hearing is rhyming with the pulse you are palpating. So you are feeling, so any murmur that occurs in between there. So you can either start with it and blow all through. In that case, it's a pan-systolic murmur. It feels the sound entirely between the first and second heart sound. It's a pan-systolic murmur. Otherwise, an ejection systolic murmur, you are hearing the first heart sound clearly, the second heart sound clearly, but there is that muffling in between. So this algorithm will help. These slides will be sent to our presenters, and also we have a YouTube channel which when we
Make a presentation.
finish the video will be uploaded, so you can subscribe and listen to it. All right.
So now we come to the concept of murmurs. Guilty or not guilty? So this is basically talking about innocent murmurs. So for innocent murmurs, they are also known as functional murmurs, inorganic murmurs, innocuous murmurs, benign murmurs, because they don't have any anatomical pathology affecting the heart. So it is heard in more than half of normal children from childhood to adolescent age, and occurs as a result of, it occurs at the origin of the great arteries as they arise from the ventricles because of the angle that they have when they are arising. So there is a relatively narrower orifice than you would see in older people. So it is more readily audible in children because of the closeness of the heart to the area of the anterior chest, because it's not as big as that of adults. So it's easily heard. And most times these murmurs are usually grade less than or equal to grade 3 in intensity. So some specific features associated with innocent murmurs. They are a type of systolic ejection murmur, and the duration is quite short, and the intensity is anything lower than a grade 3 murmur, or equal. The most it can be is a grade 3 murmur, which basically is when there is no palpable through. So, and with innocent murmurs, we will not find any other cardiac abnormalities. So when we are seeing a condition of VSD, or we are seeing any stenosis or regurgitation, it no longer becomes an innocent murmur. That is why every diastolic murmur is always a pathological murmur. And then we have the challenge is to identify children with subtle or early manifestations of a pathological condition. So generally, if we're seeing children in our clinic or the OPDs, and we are hearing a moment, we cannot just be reassuring parents that, okay, because of the age range, it is an innocent moment, they will outgrow it. Or you still have to be able to evaluate the child fully and rule out any other cause before you reassure the parents that, okay, this is an innocent momo, and you explain the whole natural history of it. So a detailed cardiovascular evaluation is essential beyond just auscultation. So
Okay. Can we ask our listeners a question from this previous slide? We'll be
okay.
glad if you just type in. What we expect from you is just a simple yes or no in the Q&A section. So Dr. Peter auscultates the precordium of an 11-month-old child and makes a diagnosis of a grade 3 pansystolic murmur, maximal at the lower left sternal edge. Is this murmur likely to be innocent or pathologic? Okay, fine. So just type innocent if you think it's innocent, or pathologic if it is pathologic. Let me repeat myself. Dr. Peter or Dr. Ella auscultates the precordium of an 11-month-old infant and reported a pansystolic murmur maximal at the lower left sternal edge. The question is this murmur likely to be a pathological murmur or an innocent murmur? The fastest fingers, let's see who is fastest. Perfect. You see, the person was too fast. I wanted to say whoever gets it will send 25 liters of petrol from Dangote filling station to the person direct. But too many people have gotten the answer just too correctly. So it cannot be an innocent murmur.
Yeah.
Why? Because it's a pansystolic murmur.
Pansystolic.
Even though the intensity, we said a murmur of less than or equal to grade 3 is one of the features of innocent murmurs, but the mere fact that it was a pansystolic murmur. So you can never reassure a mother if you are not sure of the phases of the cardiac cycle you are listening to. And you can never categorically tell the phase of cardiac cycle if you cannot identify which heart sound comes before the second one. Okay, good. So we are making progress.
Yes, we are. Okay. So we're going to be talking about common innocent murmurs. So the commonest of the innocent murmurs that we have is the Stills murmur, also called the classic vibratory murmur. So it is the commonest innocent murmur and has the following characteristics. It is a low frequency, which, as we've been saying, is best heard with the bell of a stethoscope. And it can be groaning, vibratory, or come in form of musical harmonics. And is best heard between the apex and the left lower sternal border. And we have described where we would naturally see, or what is defined as the apex. So between that and the left lower sternal border. And then it is louder in supine position and diminishes with sitting or standing. So these are some of the characteristics.
Okay, so we just to see if we remember what we've been saying so far. If a child with a murmur lies supine, and then suddenly we are hearing that that murmur is louder, is it possible that that murmur is innocent? Is it possible? So let's see again. Because we said the Stills murmur, the classic vibratory, it's actually musical. It's the day you hear a Stills murmur, it sticks in your memory forever, right? So the Stills murmur. So I'm saying, because we are supposed to listen to this, say, 11-month-old child in a sitting position and in supine position, we auscultated a murmur, let's say at the lower left sternal edge border, and when the patient was sitting up, the murmur became louder. Is that kind of murmur likely to be an innocent murmur? Yes or no? Is innocent. So that kind of a momo is innocent. Yes or no? Wow. We seem not to have fast people to type. Maybe they are used to typing with typewriter. So I will say the answer before, so that I will collect the award. Fine. It's simple. It's either a right ventricular, sorry, it's either a mitral valve prolapse or it is the hypertrophic cardiomyopathy. So we have an answer here.
Okay.
Okay, so no, someone said no. Thank you, thank you. All right, so let's go.
Okay. So we have the next innocent momo that we have the momo of neonatal physiologic peripheral pulmonary stenosis. This is a low-intensity systolic ejection momo that is best heard at the base of the heart, the axilla, and the back bilaterally on the two sides of the back. And it's usually present in the neonatal period, but can persist up to 3 to 6 months of age, and is due to poor development of the branch of the pulmonary arteries at birth and the relatively acute angle of the bifurcation of the right and the left pulmonary arteries in the neonates. So these are the things that are associated with the origin of this type of momo. So the branching pulmonary arteries, they enlarge with advancing age. So as a result of that, the momo reduces with age, and it's usually gone by 6 months of age.
Yeah, so there is the feature of the neonatal physiologic peripheral stenosis momo. It's that it tells us now that if we limit auscultation of momos to just the 4 auscultatory areas that is conventionally taught, we will miss out some momos. If we limit it to apex, lower left sternal border, second left intercostal space towards the midline, and the second right, then we will miss some momos, because this neonatal physiologic peripheral pulmonary stenosis momo, although is best heard at the base of the heart, it's also heard in the axilla. So imagine you find a child that is between neonatal life and 6 months, and you are hearing the momo also in the axilla. It tells you something. But you're hearing the momo at the back. So conventionally, we wouldn't have said the 4 auscultatory areas you are listening to, the both axilla, left and right axilla, and even at the back. But this momo in particular will hear it in those. It's because these babies are still small. The caliber of vessels leaving the heart, it decreases in diameter as it goes more distally. And because it's still a unit, the caliber, the diameter is still so small, so more turbulence, and it's branching at an acute angle. We know from mathematics that acute angles are less than 90 degrees, so it's branching off acutely. So that junction sets up the turbulence. And we hear, but like my co-presenter has said, when these babies are growing bigger, the diameters are getting bigger and adjusting in the angle, and then the momo eventually disappears. Yeah.
Okay. So these are some other common innocent momos that we can hear in children. Apart from the Stills momo and the pulmonary flow momo of newborn, we also have the pulmonary ejection momo. We have the venous home, which is a continuous momo, and we have the carotid brie, which is also another type of systolic momo. So physiological differential diagnosis of innocent momos. So these are due to non-cardiac systemic physiologic alterations associated with high cardiac output, like in cases of anemia. In anemic children, we end up seeing a faster heart rate because the body is trying to compensate for the reduced level of blood, and obviously the child will be pale. In cases of thyrotoxicosis, because of the excessive thyroid hormones, it causes tachycardia and all the other features that will be seen. So these are causes of innocent momos because there is no obvious cardiac abnormality, but that does not go to say that there is not an underlying pathology, maybe a systemic pathology, meaning that not all innocent murmurs are guiltless. So we always still have to find what is causing it. So
yeah.
okay.
So in consultation, our duty is not to auscultate the precordium. Our duty is to take care of the entire child, right? So I am able to identify classically that this is a functional murmur from anemia. And I say, okay, because your child does not require an echo, go and rest. Now that is terrible. So innocent murmurs, no structural cardiac pathology. But when there is an innocent murmur and a significant physiologic alteration, examine the entire child, because you are now finding enlarged thyroid gland. I mean, it is an innocent murmur, but it's occurring because of pathology.
Yeah.
So the child is not, the murmur is guilty, even though innocent. That is the point. So I would like presenters to go with the concept that some innocent murmurs are guilty, even though there is no structural cardiac pathology. Yeah.
Okay. And then we also have cases of athletes. So in an athletic adolescent, they generally have a slower heart rate than the normal public, but there is an increase in stroke volume because the body is also, because of their athletic nature, the body needs to pump out as much blood as it can, despite the reduced heart rate that it has. So in those children, you would see a prominent left ventricular impulse and a systolic outflow murmur, and they can have a loud third heart sound due to the increased filling phase, and there may or may not be a mid-diastolic murmur at the apex, secondary to increased flow across the mitral valve because of the increased blood that is in the ventricle. Okay. So this is just structural differential diagnosis of innocent murmurs. So if you are suspecting a Still's murmur, you make sure you rule out a subaortic stenosis, small ventricular septal defect, a pulmonary ejection murmur. You also have to rule out all these other causes. So despite the cause of the innocent murmur in quotes, you also have to be sure that there are coexisting pathologies are not there, to be sure that there is no cardiovascular pathology. Okay, so we're now going back to pathologic murmurs.
Yeah, so the guilty murmurs that have structural cardiac
pathologies, yes. So we're going to be using the NADAS criteria. Yeah. The NADAS criteria helps us to, it's like raises suspicion of a possible congenital or a possible heart defect. So we have, it could be the major.
So if we look at the criteria if we look at NADA criteria, we realize that all about cardiac pathology is not just auscultation. From the major, the minor criteria, we can see that we are taking the child as a whole and not just stethoscope. So some people use stethoscope, and they don't even know what the bell is. They don't know what diaphragm is. Stethoscope. So stethoscope, everything about cardiac congenital heart disease or abnormality with the cardiovascular is not about stethoscope. So you see that you can clearly identify, oh, this child has a systolic murmur. That is one major criterion. But that murmur is actually greater than grade 3 or equal to grade 3 intensity. That is one. So if we have a grade 2 systolic murmur, it doesn't count, right? A grade 2 systolic murmur doesn't count. But a diastolic murmur, regardless of the grade, is a major criterion. Now, if the child is cyanosed, I know cyanosis has raised a lot of concern among people who study, look at NADA criteria, because cyanosis can be peripheral, it can be central, it can be respiratory, it can come, but no problem. Is there
No
cyanosis?
cyanosis.
Put it as score of 1. After all, one major criterion is not enough because you need 1 major and 2 minor. So we have congestive heart failure there. Now, the thing is, how many doctors check blood pressure of children? So if the blood pressure is abnormal, I mean, you want to be sure you're not dealing with a coarctation of aorta, right? So you're not dealing with another part. So abnormal blood pressure, abnormal S2. My co-presenter said, among the normal heart sounds, the S2 is the most important to characterize when we are auscultating the precordium. Now, if we have a systolic murmur of grade 2, it's systolic, it's minor, not a major criterion, right? So it counts as 1 score under the minor criterion. Then abnormal chest radiograph. Now, the next few slides will dwell on practical clear images of pathognomonic signs of abnormal chest radiographs. Now, this done, we believe that major criterion 1 to 4, minor criterion 1 to 4, any doctor can pick that abnormality. The abnormal ECGs that look, this ECG is looking somehow. It's just like this is looking somehow. That is enough. You can, as part of Limi Hospital continuing medical education, there is a WhatsApp group for members of the symposium community. You could send that ECG into that WhatsApp group. You are sure to get an explanation within 24 hours, right? So any of these 2 minor, 1 major has a high sensitivity and specificity to positively predict that this child requires further evaluation to rule out congenital heart disease.
Okay. So abnormal findings.
Look at the abnormal chest radiographs.
Okay. So abnormal chest findings that we can find on radiograph, it could be in the abnormal silhouette of the heart. It could be where we'll see maybe a boot-shaped heart. In tetralogy of Fallot, we can see an egg-shaped heart in transposition of great arteries, or a figure of 8 or snowman sign, which is seen in total anomalous pulmonary venous return. Figure of 3 can be seen in coarctation of the aorta. We would have visual representation of this. So for abnormal cardiac size, it could either be large or extremely large. We could also have abnormal aortic position where there is presence of right aortic arc instead of the left, which can be seen in transposition, tetralogy of Fallot or persistent truncus arteriosus. Then you can also see an abnormal liver position where the liver can be midline, where we have a midline liver complex cardiac defect, which could be associated with asplenia or polysplenia. So this is a chest radiograph showing a normal heart with the normal positioning of everything: left ventricle, right atrium, the inferior vena cava, aortic and pulmonary arteries. So in this case, we see a boot-shaped heart. The heart is not enlarged, it's just boot-shaped, which is seen in tetralogy of Fallot. This is an egg on string.
Yeah. So sorry. So back to the boot-shaped heart a little. So this classical boot-shaped heart, we know that the abnormalities in tetralogy of Fallot, they're a tetrad of abnormalities, where the main pathology, most severe, is a right ventricular outflow tract obstruction. So if we go back to the previous slide, just go back to the previous slide, so that we locate the pulmonary area. So just cram this pulmonary area now. And in tetralogy of Fallot, we said that there's pulmonary stenosis. That area is stenosed, so it will be compressed. When it's stenosed, it's going to reduce the size of the superior mediastinum. Now, still on this, we said, no, still go back. Still looking at the features of tetralogy of Fallot, we said that there's because the the pulmonary outflow tract is enlarged. The apex, another abnormality is that there's a large ventricular septal defect. The aorta is overriding, and then there's thickening of the right ventricular wall. That thickening of this right ventricular wall that forms the base makes the apex to tilt upwards. In this normal chest radiograph, the left ventricle is pointing downwards. The base of the heart is formed by the right ventricle. So if it hypertrophies, it's going to push that tip upward. So now let's see the left, the TOF. Good. So we see that the tip is kicked forwards because the base is larger. So it kicks the tip upwards. The area that should be pulmonary is narrowed. So you are having that narrower superior mediastinum, right? So if we see this, it is classic of tetralogy of Fallot. All right. Okay. So, but the question is, from one of the earlier slides presented, I have a funny question to always ask junior doctors. The boot-shaped heart is pathognomonic of tetralogy of Fallot. True or false? So can we get answers in the chat box? The boot-shaped heart is pathognomonic of TOF. True or false? If it's true, write T. If it's false, write F. Let us see.
We have one T.
Okay. We have one. You know what? Please go backwards. Go to the slide before this. Go back. Okay, fine. At this point, you can see the boot-shaped heart, you think of TOF. In fact, it is not all TOFs, because the pink variant of TOF will not have a boot-shaped heart. Now, a tricuspid atresia will also have a boot-shaped heart. So back to the question, a boot-shaped heart is pathognomonic of tetralogy of Fallot. True or false? Good. So let's progress. Food for thought.
Thank you.
Okay.
So
this is egg on string appearance, which is classical of transposition of great vessels. Okay.
Here we have the figure of 8, or the snowman sign, which is seen in total anomalous pulmonary venous return.
Yeah. So in that same image of snowman sign, in total anomalous pulmonary venous return, there is a plexus of veins, the pulmonary veins, that form normally the 4 pulmonary veins, left anterior, left posterior, right anterior, right posterior, empties into the left ventricle. But in total anomalous pulmonary venous return, all these veins form an association. Maybe it's Nigerian Labour Congress, or it's NMA, or it's JOESU. They form an association. And that is seen as the shadow above the normal, so the upper edge of the 8, that's the shadow above the cardiac shadow, is actually a shadow casted by the plexus of the veins that now empty into the right atrium. So that gives it the normal shadow forming the lower circle, the plexus of veins forming the upper circle. So that is the snowman sign, classic of total anomalous pulmonary venous.
Then here we have the coarctation of the aorta, which we see the classic 3-figure sign. So in this case, here we have, there's a post-stenotic dilation. We have the area of stenosis just here. And then in for this straight arrow, it shows the dilated subclavian artery. So because as a result of the coarctation of the aorta, the areas above and below the coarctation, they tend to be ballooned up. So there's going to be dilated subclavian artery after the coarctation of the aorta, And then just prior to it, there's going to be a post-stenotic dilation.
Yeah.
Okay.
Yeah. So there's an echo image that is beside it, which has shown everything that was said. The echo image beside it shows the dilatation pre-stenosis and the dilatation post-stenosis and the points of coaptation. Okay. All right. So we appreciate your listenership because this is actually our second to the last slide. We had discussed NEDA criteria as one of the indicators for suspecting cardiac abnormalities, that's congenital heart disease. But in this is a newer one published just a few years back, 2020, which is a clinical scoring to detect congenital heart defects. So this is a second screening after NEDA criteria, which is possibly ancient, right? So it looks at history and examination findings. Now, if we get up to 3 or more abnormalities, then we strongly suspect a congenital heart defect. You see, bluish discoloration is similar with cyanosis in NEDA criteria. Then this is taking the child in a whole context. So the child feeding with difficulty, sweating, that is a score of 1. Difficulty with breathing, score of 1. Precordial pulsation, failure to thrive. If there is a cyanotic spell, then that is significant. If there is a cyanotic spell, that is significant. That takes a score of 2. If there's a family history of congenital heart disease, takes a score of 1. Now, by the time we go to the other findings, clinical examination findings, clinical stigmata of specific syndromes. So if we see that the ear is low set, and we see the epicantic fold, we see the features that suggest Down syndrome. So a Down syndrome patient automatically has a score of 1. You just need 2 or more scores to complete your suspicion to screen for congenital heart defect. So for all this, if you hear a murmur, so unlike NEDA criteria that said all diastolic murmur major, all systolic murmur greater than or equal to grade 3 major, and systolic murmurs, but this one, once you can hear a murmur, is grade 2. This is because we want to increase the positive predictive value of our clinical examination findings so we can detect congenital anomalies as fast as possible. Because we know the earlier we diagnose them, send for commence treatment or medications before they go for surgery, the better the outcome. Yeah.
Okay.
All right. So good.
In conclusion, to conclude, cardiac auscultation is an ancient yet golden skill to be developed in clinical practice. And abnormal heart sounds, from all our explanation, we can conclude and say that they are not all murmurs, because we have the third heart sounds, we have the fourth heart sound. Then all murmurs
we have the abnormal splitting of the second heart sound.
Exactly.
So
we have the
splitting of the second heart sound is an abnormal sound, but it's not a murmur. Yeah.
All murmurs are not pathologic. Some are innocent, but in the same breath, not all innocent murmurs are guiltless.
Yes. Yeah. So we thank you, dear listeners, for your participation and holding on with us, despite the network glitches from time to time. We hope that next time when you pick up the stethoscope that is on the dashboard of your car and you place it on the precordium of the child, you will follow all the steps needed. We are open to questions, honestly. We are open to questions. We want to clear any doubts so that we can do better to
Yes.
these babies that we listen to and that we take care of. Yeah. So we appreciate that. The next slide.
Okay.
Okay, thank you. So
You.
as we're rounding up, we said next slide, next slide. So we are Limi Children's Hospital, and our address can be located as you can see it. We get referrals, and please, we want them to come early. In the last 1 week, I've seen 2 children with congenital shunt lesions that have developed pulmonary hypertension. They would have to go for right heart catheterization. And then if it's too high, you are not talking of a heart-lung transplant. That is not funny at all. When we get them early, we treat them early, they get a better outcome. This is Limi Children's Hospital presenting. In the next 2 weeks, Cardio Care, which is a branch of Limi Hospital, will also be presenting. So Limi Children's Hospital will present once a month. The Cardio Care aspect of Limi Hospital will present once a month. Thank you. We will appreciate that we end at this point.